All right. Physiology of hematology. So, so when we talk about physiology of hematology, so the components that I'm going to talk to you, I'm going to tell you about I'm going to talk to you about composition of blood, their various components, and what is their individual role to play, and why we need those roles to play. Then also how a blood clot is formed, what is called coagulation cascade, what is the role of various cellular components in that. Then also what are the then what is about then also I'm going to talk to you about immunology. What are the types of immunology, and what are the cells which play a role in immunology, and also I'm going to give you some examples on various types of immunological problems, and also finally I'm going to discuss very briefly on immunological disorders. So that's the content of tonight's lecture, right? So physiology of hematology, under that we are going to first discuss about components of blood. So when we take components of blood, there are several elements of blood. So there's a liquid part, which is the floating one, which is called the plasma. There's a fluid. So in our blood, we have a fluid component like water, a watery component. That's the fluid part. The fluid component or the watery component, that is plasma. Inside plasma, you have various minerals, vitamins, the electrolytes, uh, various complements, various substances dissolved in this plasma, right? You have sodium, you have potassium, you have glucose, you have albumin, you have so the various proteins, various minerals, everything is embedded, dissolved in this plasma. So in this plasma or our fluid component, you also have embedded cells in it. So we have plasma and also we have cells in it. So if you take if you take 100 ml of blood, out of that 55% is plasma. What is the color of plasma? You can see here, like when you spin a sample of blood collected to a tube in a spinning chamber, you can see plasma will be straw colored, yellow colored or straw colored. So 55% of your blood will be plasma. Then inside plasma you have various cellular components which is embedded in that. So there are three main cell components. What are they? The white cells, the red cells, and also the platelets. So you can see here the red cells are here. The red ones are the red cells. So that comprise about 41% of your cellular component. About 41% of your cell, or some literature it says 45% of your cellular component, right? And then you have your white cells, right? Then you have your white cells. So white blood cells they comprise about 4% of your cellular component, white cells. So red cells 41% and the white cells 4%. So that is why your blood is not white colored. Why? White cells are only 4%. Your blood is red colored. Why is that? Because that yellow colored or straw colored plasma, they have mainly embedded red cells in it. So look at this percentage. So 55% plasma and 41% red cells. So red cells are a huge number. So look at this test tube. So in this tube you can see the plasma is 55% and 45% is red blood cells. So that means large amount of red blood cells embedded in plasma. So therefore the red cells are red colored because of their hemoglobin. So therefore, your blood is red in color. Okay, that's why your blood is red in color. That is because there's a large amount of red cells embedded in plasma. Otherwise, your blood should be yellow colored if it was mainly plasma, or it should be white colored because of white cells. But it's not like that. The main cellular component is red cells, and because of this large majority of red cells, about 45%, your blood looks red in color. So you can see here 45% of your blood component is red cells and 55% plasma. So the white cells and platelets, so they say the platelets are less than 1% and the white cells about 4%. So different books, different percentages. So white blood cells and platelets only very small component. White blood cells and platelets, but they have a huge role to play. They have a very important role to play, though they are small in number, but they are small. So remember, they have a small percentage. So main component is plasma 55% And then you have your red cells almost like 41 to 45%, and your white cells and platelets are only a minority, small component. All right. So you can see, so when you take red cells are biconcave in shape. No, biconcave. This side also concave and this side. So we call it biconcave. When the shape is like this, we call it biconcave. Right? So it's the biconcave shape. So why does the red cell adapt this size? Because when it has to pass through capillaries and also small tiny blood vessels, they have to adapt into this shape. So that's called biconcave shape. Okay. And then you have the white cell component. You also have the white cell component. So in the white cell component, you have all these types of cells. You can see here, you have the main type is neutrophils. So neutrophils, you have 3 to 5 segments in neutrophils. How many segments? Here you can see 3 segments. Can you see this, guys? There are 3 segments in neutrophils. Can you see that? All of you? Yeah. So here there are 3 segments. Usually you have 3 to 5 segments in a neutrophil. 3 to 5 segments in a neutrophil. Then you have and also they have granules, so we call them granulocytes. Then the other granulocyte is eosinophil, is usually bilobe, is like kidney shaped. Eosinophils are like kidney shaped. So you can see the 2 lobes here, one lobe of kidney, the other lobe of kidney. So it's a kidney shape, it's like kidney bean, right? So eosinophil is a bilobed structure, and that's also having granules. Those granules mainly contain histamine. That's why in allergic response or allergic reaction, you have release of histamines from eosinophils. Then also you have the other type of granulocytes that's called basophils. They all play their individual roles in immune response and also allergic responses. So those are granulocytes. Then also there are agranulocytes. Agranulocytes means they do not have any granules inside, they are white cells. So these are differential cells. In the when you take the total white cell, there are various differential cells. Differentials are neutrophils. So differentials you can divide as granulocytes, agranulocytes. What are the granulocytes? The neutrophils are there, eosinophils are there, and the basophils are there. I taught you that. Then you have agranulocytes. That means you do not have granules inside those types of white cells. What are they? You have lymphocytes. So here you can see the lymphocytes. They are very tiny, small white cells, lymphocytes. But though they are tiny, they play a huge role in your immune system. Why? There are 2 types of lymphocytes. One is called T lymphocytes. The other one is called B lymphocytes. T lymphocytes, again there are 2 types. One is called helper T lymphocytes. They help in the immune response and also phagocytosis. The other type is called cytotoxic T cells. Cytotoxic T cells, they destruct various bacteria or various viruses. So, you know, when you get the HIV infection, these cytotoxic T cells or the CD8 cells, they get destroyed. They reduce in number when you get HIV infection. So, this is practical hematology. So, when you get HIV, the cytotoxic T cells or the CD8 cells, they get reduced in number. So B lymphocytes, they produce antibodies. So we have various antibodies, and our B lymphocytes are the ones which produce those antibodies, which we are going to talk to you in the immunology lecture, right? So lymphocytes, there are 2 types, T lymphocytes, B lymphocytes, and T lymphocytes again divided into another 2 types. What are they? Helper T lymphocytes, or what you call the CD4 cells. Sorry, I said, yeah, CD4 cells. So CD4 cells are the helper T lymphocytes, and the I said CD8, I'm sorry. In HIV infection, CD4 cells go down. No, not CD8, I'm sorry. I just made a small mix up there. So in HIV infection, CD4 lymphocyte count drops down. So therefore, they get a reciprocal elevation of CD8. So CD4 T cells are called T helper lymphocytes, and the CD8 T lymphocytes are called the killer or the cytotoxic T lymphocytes. All right, and HIV infection affects CD4 T helper lymphocytes. Then the other cell type of white cells are called monocytes. They also play a role in the innate immunity. Then you have very tiny particles, the very tiny structures in the blood. They are called platelets, very small in number, tiny cells. They are called platelets, right? So platelets, they are very small in number, but they are also very important components in our blood. All right. So these are the components of our blood. So next slide, we are going to talk to you about the importance of red cells. You know, in our blood, we have these red cells. Why do we need red cells? So inside these red cells, you have what are called structures called hemoglobin. So inside the red cell, you have structures called hemoglobin. Hemoglobin. What do? They bind oxygen. So oxygen is bound to this hemoglobin, and these red cells, when they float in blood, and then the oxygen bound hemoglobin will be floating in your blood to the target organ. So remember, your target organs like the brain, your heart, your kidney, your muscle cells, any cell in the body, anything in the body, all the cells in the body, they need oxygen, they need glucose, and they need nutrients. Why? For the energy production. They need ATP for their cellular functions. So because they need ATP for their cellular functions, they need oxygen, and also they need nutrients. So oxygen is carried bound to hemoglobin. Oxygen is carried to the peripheral tissue or the target organ bound to hemoglobin. So that is why we need red cells, and inside red cells you have hemoglobin, and oxygen binds to these structures called hemoglobin. Right. So how do we get oxygen? When we breathe in air, the outside from the atmosphere, from the atmosphere, we breathe in oxygen, and the oxygen will come to our lungs, and then in the lungs you have this blood, the alveolar capillary basement membrane. Alveolar capillary basement membrane. So they are oxygen in the lungs, they diffuse. So if you take like this, these are lungs, and they get their blood supply from the pulmonary artery. So pulmonary artery brings your deoxygenated blue colored blood from the right side of the heart. That heart is too small. From the right ventricle, blood, so this RA, this RV from the right ventricle, blood is carried by the pulmonary artery into lungs. So the lungs, this pulmonary artery, they divide into various branches, and then at the capillaries, they form pulmonary vein. The pulmonary vein, so they are whatever oxygen from the atmospheric air, they diffuse into these pulmonary veins. And in the lungs, whatever carbon dioxide which was carried in this dirty blood or the deoxygenated blood will be released back into the lungs, isn't it? So carbon dioxide is released into the lungs from the blood, and so there's a purification mechanism, and the oxygen from the atmosphere, they come to the lungs, and in the lungs, oxygen diffuses into the pulmonary veins, venules. And then this bright red oxygenated blood comes back into your left atrium, then to the left ventricle, and from the left ventricle to the rest of the body, like the brain to the heart, so the rest of the body via what is the structure? Aorta. No? Aorta will bring the blood to rest of the body. All right. So this is our normal oxygenation and deoxygenation breathing mechanism. All right. So now once you get oxygen into your red cells, these are floating in your blood to the target organ. So that's why you need red cells. Okay. So where are these red cells being produced? Red cells are produced inside a structure called bone marrow. Inside a structure called bone marrow. So in our long bones, like the humerus, then you have the radius, and also you have your, in your leg you have your femur, right? You have your femur, and also you have your tibia. These are the long bones. So inside these long bones, you have a structure called bone marrow. Inside the bone marrow, you have production of cells. Is it only red cells? No. Production of red cells, white cells, and the platelets. And they happen in 3 series. These series are called, so production of cells are called hematopoiesis, or blood production. The blood cell production is called hematopoiesis. Poiesis means production. Hemato means blood. Blood production, hematopoiesis. Understood, guys? So there are three main cell types being produced. They're the red cells, the white cells, and the platelets. So the red cell production is called erythropoiesis because erythrocytes are produced, erythropoiesis. And the white cell production is called granulopoiesis, right? Because mainly the granulocytes have been produced. And the platelet production is called megakaryopoiesis. So you have erythropoiesis, then you have granulopoiesis, production of white cells, and you have the megakaryopoiesis, which produce platelets. So these are the three cell lines or three series of production of cells which happens in the bone marrow. So for this production of cells, you need lots of substances. There are stimulants and inhibitors. So the most important stimulants are, particularly for production of red cells, you need erythropoietin. Erythropoietin is produced by what structure? Kidneys. So kidneys produce 90% of your erythropoietin, and up to 10% is produced by your liver. So erythropoietin secreted by kidney play an important role inside the bone marrow for the production of red cells. You also need lots of vitamins. What are the vitamins? You need vitamin B12, you need folic acid. Why? For the production of the cell DNA. For the DNA production, you need folic acid. Without folic acid, you cannot manufacture DNA. You also need vitamin B12. That's why B12 deficiency leads to anemia, macrocytic anemia, macrocytic megaloblastic anemia. Also, there are various other components here for the cellular production in addition to these molecules. Okay, right. Right. So I told you erythropoiesis, granulopoiesis, and megakaryopoiesis. All right. So now we are talking about the red cell. Okay, we are talking about the red cell. So when the in the erythropoiesis, guys, so who is giving these red cells? Who is making this erythropoiesis process? That is the red cells. When they come in the erythropoiesis pathway, they have a progenitor cell. Progenitor cell means the precursor cell. So there are grandparental cells, and that's called the progenitor cell or the stem cell. From the stem cell, there are three divisions. One is erythropoiesis division, the other one is granulopoiesis division, and the other one is megakaryopoiesis division. So those are the three divisions of cell lines from the stem cell in the bone marrow. So in the stem cell, for you to produce various these cell lines, you need various substances. One very important substance is called GMCSF. I'm going to show you those pictures. GMCSF. That is granulocyte, macrophage, colony stimulating factor. Like that, there are lots of other substances which we are going to talk to you now. Right. Let's go to our slide presentation. So you can see here the manufacturing of red cells. You can see here in the lungs, you get, so carbon dioxide is released into the lungs and oxygen is coming from the lungs into the pulmonary veins. And that is to the left atrium. And from the right ventricle, you have this dirty deoxygenated blood released into the lungs as carbon dioxide. And this is the blood flow. And these are the ways how red cells carry out the inside the hemoglobin, like bound to hemoglobin inside the red cell, how oxygen is carried to the peripheral tissues. So in the peripheral tissues, here is the oxygen transport and carbon dioxide transport. So in the peripheral tissues, you have oxygen for the cells to produce ATP for the energy production. So that's why you need red cells. That's why you need hemoglobin, and that's how oxygen being transported to peripheral tissues. Understand, guys? So there are problems of red cells or hemoglobin. When there's not adequate hemoglobin in the molecule in the red cell, what do you call that? Anemia. When there's deficiency of red cell hemoglobin, you call it anemia. And some people, they have excess of hemoglobin in their red cells. What do you call that? Polycythemia. I have taught that in the hematology lectures. Even in the restreaming lectures, I have taught you that. It's not just a restreaming. Along with restreaming, I have been lecturing as well. Quite a lot of lecturing and teaching. So hemoglobin, when there's deficiency, you call it anemia, and when there's excess, you call it polycythemia, right? So anemia, we have done this classification of anemia. Microcytic anemia, when the red cells are very small in size, we call them microcytic anemia, like iron deficiency anemia, because iron is needed for this hemoglobin production. Iron is the main component. So iron deficiency causes small cells, microcytic anemia. Thalassemia causes microcytic anemia, that is less than 80 femtoliters, that means small red cells. Then sideroblastic anemia also produces microcytic anemia. Then you have certain anemias where you get large red cells, what we call macrocytic anemia, B12 deficiency, folic acid deficiency, cirrhosis, alcohol, myelodysplastic syndrome, hemolytic anemia, and hypothyroidism. These are the 7 causes of anemia where you have large red cells, and we call it macrocytic anemia. What are they again? I'll quickly revise. B12 deficiency, folate deficiency, right? B12 deficiency, folate deficiency, then cirrhosis, alcohol, hypothyroidism, and myelodysplastic syndrome. Okay, and also hemolytic anemia. These are causes of macrocytic anemia. Then, guys, you have anemia with normal size red cells. We call them normocytic anemia. What are the causes? What are the examples? Anemia of chronic disease. So any chronic disease can produce anemia, and that is normocytic anemia. The red cell size is 80 to 96 femtoliters, which is the normal size red cell. Right? Anemia of chronic disease. Any malignancy produces normocytic anemia, except if the malignancy is bleeding, like gastric carcinoma, then of course you will end up with iron deficiency also. But otherwise, normal malignancies, you get normocytic anemia. Acute bleeding. Chronic bleeding produces hypochromic microcytic anemia due to iron deficiency. But acute bleeding, like after road traffic accident, after major surgery, you present with normocytic anemia. Chronic kidney disease, that also produce normocytic anemia. Most of the endocrinological disorders other than hypothyroidism that also produce normocytic anemia. Why? Hypothyroidism produces macrocytic anemia. Right. Anemia classification also I have covered here. All right. Good. So when do you call anemia? In a man if the hemoglobin is below 14, and in a woman when the hemoglobin is below 30. Pregnancy values are different because in pregnancy you get what is called dilutional anemia. Polycythemia is when your hemoglobin goes above 18 grams per deciliter. Right. Then a little bit about hematopoiesis, the cell production. So you can see here, this is a cut section of a bone. So this is the outer covering or the cortex of the bone, and this is the spongy layer of the bone. And here inside, right in the middle, you have this structure called bone marrow. It's a very vascular structure. You can see the blood vessels there. So this is the place where you have production of cells in your long bones, the bone marrow. In this bone marrow, you know, iron is being stored in the bone marrow as ferritin. The ferritin is found in bone marrow. Iron is stored there inside the bone marrow as ferritin. All right. Okay. So when you have, small. Oops. I'll make this one small so that. So now you can't see me, don't worry about it, because I want to show you this slide presentation fully. So you can see here, now the cell production, during the cell production, there's a parental cell or what you call stem cell. This is the hematopoietic stem cell, this is the progenitor cell, actually before the progenitor cell, the grandparental cell called stem cell. This is called the stem cell. We can't put that in. Okay, so this is the stem cell, guys. This is the grandparental cell in the bone marrow, and this is the one which is going to produce all these mature cells you can see in this column, which you can see in our blood. So see this stem cell. So stem cell divides into this common myeloid progenitor cell, and then so you can see here, no, this is the first division. So you can see 2 divisions here. You can see the 2 divisions. So the stem cell divides into common myeloid progenitor cell and also common lymphoid progenitor cell. Okay. So And when you take this myeloid progenitor cell, so can you see here this very important substance? I'm encircling that. Please follow my cursor. GMCSF. Did you notice that, guys? GMCSF. That is granulocyte macrophage colony stimulating factor. GMCSF. This is so important because certain patients where they do not have enough white cells, we do inject this substance intramuscularly called GMCSF. So GMCSF is injectable, right, in the necessary patients. So this stem cell, for it to differentiate into various progenitor cells, you need GMCSF or granulocyte macrophage colony stimulating factor. Please don't draw on your laptop so that we get interrupted, like our lecture gets disturbed. Then also you have various interleukins like interleukin 3 playing a huge role in this making a progenitor cell. Right? So here also you can see this also a progenitor cell. This is the myeloid progenitor cell. This is the lymphoid progenitor cell, and there also interleukins play a role. Right? From this progenitor cell, here you can see from the progenitor cell, you have development of this erythroid progenitor cell. Erythroid means the red cell precursor. So from the erythroid progenitor cells, you produce, so we call it megakaryocyte erythroid progenitor cell. In one pathway, with the production of or with the help of erythropoietin, you produce what are called erythrocytes or the red cells. And the other pathway, with the help of this thrombopoietin, you produce what is called platelets. So erythropoietin will produce erythrocytes and thrombopoietin will produce platelets from the progenitor cell. So here you can see the granulocyte macrophage progenitor cell, and that will divide into a myeloblast. So you don't have to remember these things. No need. I'm just explaining your physiology. So progenitor cells, they divide into what are called blast cells, myeloblast. So you can see a myeloblast then mature into basophils, eosinophils, and neutrophils. So these are the cells that we find in our bloodstream: the neutrophil, eosinophil, and the basophils and mast cells. What did I tell you about these three structures? These three cells, they have granules inside them. So we call them granulocytes. Granulocytes. They have granules inside them. And what is the main cell type? Neutrophils. Then, guys, so these myeloblasts, the other series is monocytes. And the monocyte differentiate into what is called macrophage. Macrophage. The lymphoid series, guys, these are the lymphoid series. So lymphoid progenitor cell, that will divide into T lymphocytes and the B lymphocytes and also natural killer cells. Okay, so I'm going to show you this picture again. I'll just minimize this. So these are the mature cell types that we see in our blood. What are they? The red cells or the erythrocytes. You have the platelets. Then you have the three granulocytes, the basophils, eosinophils, and the neutrophils. And then you have the agranulocytic structure, the monocytes, and also the macro, which divide into macrophages. And then you have the lymphocytes, lymphoid series. You have the T lymphocytes, B lymphocytes, and also you have the natural killer cells. So these are the types of cells that we see in our bloodstream. Understand, everyone? Is that clear to everyone? Is that clear so far? No? Stupor state. Catatonic schizophrenia. Right. Guys, what I taught you was how the cells being produced in the marrow. So in the marrow, you have the stem cell, grandparental cell, with the help of GMCSF, granulocyte macrophage colony stimulating factor, that divides into various progenitor cells. These progenitor cells, when they in their erythropoiesis pathway, with the help of erythropoietin, they will produce red cells. With the help of thrombopoietin, they will produce they will go in the megakaryopoietic pathway and produce platelets. And they will, with the help of these progenitor cells, with this granulocyte macrophage colony stimulating factor, they will go in the granulopoiesis pathway and produce the three mature granulocytes. What are they? Neutrophils, eosinophils, and the basophils. And also you will have the agranulocytic macrophages that from the mast cells. Then, guys, from the monocytes, I'm sorry. Then you have another pathway called lymphoid progenitor cell. The lymphoid progenitor cell will produce the T lymphocytes, B lymphocytes, and the natural killer cells. Is it okay? Whom do we inject granulocyte macrophage colon stimulating factor? The people, those who go into severe neutropenia. Some patients, they go into a condition called severe neutropenia. And if you go into a state of severe neutropenia, particularly malignant patients or people, those who go into severe septicemia. So those people, we inject GM-CSF. Okay, right. So now you have understood what is the role of our bone marrow and how they produce various types of cells. And what are the mature cells, how they are being produced inside the bone marrow, now you all know from the stem cell. And the substances which play a role in the hematopoiesis, also you know what are the GM-CSF and interleukins mainly. Is that clear? So here it again shows the types of cells that you get. So here you can see the hematopoietic stem cell. From the stem cell, you have the myeloid progenitor and the lymphoid progenitor. From the lymphoid progenitor, you get the T cells, B cells, and the NK cell or natural killer cell. From the common myeloid progenitor, you have two pathways. One is megakaryocytic erythroid progenitor. Megakaryocytic means platelets. Erythropoietic means red cells. So megakaryocytic erythroid progenitor cell, this one, and that divide into red cells with the help of erythropoietin, also divide into platelets with the help of thrombopoietin. So erythropoiesis, megakaryopoiesis. Then you have this granulocyte macrophage progenitor cell, which divides into neutrophil, uh, eosinophil, and basophils. Those three are granulocytes. Also, you have agranulocytic monocytes, which divide into what? Macrophages. All right. So those are the types of cells and how they've been produced in bone marrow I have taught you. This is another pictorial explanation of what's happening in the bone marrow. So the stem cell, from the stem cell, you can see with the help of interleukins and also GM-CSF, you produce various progenitor cells. Right? So this is the stem cell, and that divides into various progenitor cells. Here you can see the progenitor cell, common myeloid progenitor cell. And also you have the common lymphoid progenitor. This is the common lymphoid. So you have common myeloid progenitor cell, you have common lymphoid progenitor cell. Lymphoid progenitor cell, very easy. T lymphocytes, B lymphocytes, and natural killer cells. And the common myeloid progenitor cell, that has two pathways. What are they? The megakaryocytic erythroid pathway, and also they have granulocyte macrophage progenitor pathway. So in one pathway, granulocyte macrophage progenitor pathway, they produce the neutrophils, basophils, and eosinophils, which are, these three are called granulocytes. You can see these tiny dots inside the cell. That's why we call it granulocytes. And also from your monocytes, they are agranulocytes, they don't have granules. From your monocytes, you produce macrophages. And here you can see the megakaryocytic pathway, megakaryocytic erythroid pathway. Here you have production of platelets and also you have production of red cells. And here the lymphoid progenitor pathway, they will produce T lymphocytes, B lymphocytes, and the natural killer cells. Is that clear? Very simple, right? Good. Right. What are the substances? What are the components which play a role in this hematopoiesis pathway, hematopoiesis process? So I told you vitamin B12 and folic acid, very important, very essential for your cell production, particularly red cell production. Even the white cells and platelets, they need vitamin B12 and folic acid. Why? Folic acid needed for the DNA production. So essential for formation of thymidine, there we go. That's what I told you, B12 and folic acid. Thymidine triphosphate. So essential building block of DNA. So you don't have to remember this thymidine and all that. All what you need to know is B12 and folic acid are needed for your building block of DNA. So diminished DNA, failure of nuclear maturation, and inadequate erythropoiesis. So ultimately you end up with anemia. So other vitamins which play a role, pyridoxine or B6, riboflavin, nicotinic acid, biotin, and also vitamin C and vitamin E. All right. So the vitamin B12 is needed here in extrinsic factor, maturation factor, and also cobalt containing vitamin. So here look at this erythroblast. Erythroblast, I told you from the erythroid progenitor cell, guys. Before you get the red cell, you have this erythroblast, then you have the reticulocyte, and then you have the red cell. I'll write it for you. So this is the mature red cell. So before the mature red cell, you have what is called reticulocyte. It's an immature cell. Why did I say immature? Because it has a nucleus. The mature red cell, they don't have a nucleus. Here you have a nucleus. It's immature reticulocytes. Before that, you have normoblasts. And also you have erythroblasts. Erythroblasts, normoblasts. They only divide into reticulocytes. You don't have to remember these, only. Okay, so here I have clearly mentioned B12 and folic acid, they are needed for erythrocytes, erythropoiesis. And lack of B12 and folic acid, they will also will lead to production of large red cells with excess hemoglobin, excess concentration of hemoglobin. That's called megaloblastic anemia. They are large red cells. It's all due to lack of DNA. So principal causes of a disturbance of erythropoiesis I have mentioned there. Hemoglobin synthesis is impaired in iron deficiency. We all know that. Hemoglobin production is markedly affected. Why? Because that is the main component of your blood, the red cells. So hemoglobin synthesis is greatly affected due to iron deficiency anemia, because that produces microcytic hyperchromic anemia. Then also cell multiplication. I told you that, guys. For the cell multiplication, cell division, you need DNA. DNA is the molecule which divides among the cells, daughter cells. So for the DNA to, you need to, for the DNA division, you need adequate amounts of folic acid and also vitamin B12. So DNA synthesis will be affected when you have folic acid deficiency and also B12 deficiency. Right. So now we know about the red cell, its function, and how it's been affected in various problems we have understood now. The white cells. Now the white blood cells, they are a minority in your blood, but very important cells. Why? They play a huge role in your immune process. They play a huge role in your immunity or immune process. What do they do? So, so I have given you the classification here. The white blood cells that protect 100 trillion cells in our body. What are they? So first, the neutrophil. You can see here offers 1, 2, 3. Yes, 3 segments. Right. So neutrophils has 3 to 5 segments, and their lifespan is about 7 hours. So short duration, and the function is they play a huge role in immune defenses. Immune defenses. Particularly, they play a role in what is called innate immunity. Innate immunity. A call from the hospital. Hello. Yeah. Any neurological inflammation? Huh? Hmm. Any bleeding manifest? Yeah. 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 No, you don't do like that. You have to do it after 6 hours only. You don't do it in 2 hours time. WBCT you have to repeat after 6 hours. If one is clotted, so the reliability of the bottles or tubes in the ward you have to recheck whether they are washed properly or anything like that. Why don't you urgently check the PTINR and APT? Okay, so the neutrophils, guys. So neutrophils have a short lifespan of about 7 hours, and their main function is the immune defenses. Immune defenses. So they play a huge role in the innate immunity, or what we call first line defense. So when a bacteria enters our body, or a virus enters our body, or a fungus enters our body, the first line defense immediately to the forefront, the cell which is going immediately to the forefront is neutrophils. So these are and neutrophils are a key component of your innate immunity. Innate immunity. Then you have the second cell type called eosinophils. And the eosinophils, they have 8 to 12 days lifespan. And here you can see their bilobe structures, two lobes, bilobe structures. And they have defense against mainly parasites. That's why, guys. So I'll tell you some practical examples. Let's say when you get a parasitic infection, like maybe worm infections. So maybe like worm infection, you have elevation of eosinophil count. So when you have worm infestation, you have elevation of eosinophil count. So eosinophils, they'll be elevated in parasitic infections, and they are the main defense against parasites. Then you have the basophils. So basophils, they can last in blood for a few days to few hours to few days, and that is playing a huge role in the inflammatory response. So in our body, for the inflammation to occur, you need basophils. So basophils play a huge role in immune response, inflammatory response, and also immune response. Then you have the monocytes. They last for about 3 days, and they also play a huge role in their immune surveillance. That is by producing macrophages. Monocytes, they progress into macrophages. Then you have the monocytes. Monocytes, what is their role? They have immune surveillance as well. So just like your previous one, that is immune surveillance. Yeah. So immune surveillance by the monocytes. Then, guys, the very important lymphocytes. What are they? I told you already. B lymphocytes and T lymphocytes. B lymphocytes play a huge role in the antibody production. So these antibodies are the armamentarium, like they are the weapons. These weapons go and attack the bacteria, attack the virus, or what. So antibodies are being produced by the B lymphocytes to go and attack the cells. Then the T cells are there. T cells, there are two types: helper T lymphocytes and also killer T lymphocytes. So the powerful one is the killer cell, CD8. The cytotoxic T cell. Okay. So white blood cell components and their various functions have been summarized in this chart. So neutrophil, I told you, general phagocytosis, acute bacterial infections. In that only the neutrophils play their main role. So what is that? General phagocytosis. And also in acute bacterial infections. Because whenever you get a bacterial infection, what happens? Your neutrophil count goes up. In viral infections, the neutrophil count doesn't go up, but bacterial infections, the neutrophil count goes up. They get neutrophil leukocytosis. Neutrophil leukocytosis. Same thing is true after infarction or inflammation. So whenever you get inflammation or infarction, your WBC gets reactively elevated. Like best examples are diabetic ketoacidosis, myocardial infarction. In those conditions, the white cell count can reactively go up. So the functions of white cells, so the neutrophils generally what do they cause is phagocytosis. What do you mean by phagocytosis? So you have phagocytosis, something like this. I'll just draw it for you. I can erase this too. Phagocytosis, now say this is the cell, macrophage or something. Here they are some antigen or maybe bacteria in your blood. So the phagocytosis, what do they do? Initially, they get closer to the bacteria or the organism, and they get attracted to the organism. They get attracted to the organism. Then after that, they get attached. The organism gets attached to this. Then what do they do? Yeah. Then they encroach. The cell encroaches this foreign bacteria or foreign virus. So when it encroaches, then it can release all its substances and they can kill the bacteria. Understood, guys? So this is what's happening in phagocytosis. That is, they make the bacteria or virus or whatever foreign substance easily palatable. Phagocytosis. Okay, so neutrophils, guys, is general phagocytosis and it's very important in acute bacterial infections. Right. Next cell type is eosinophils. They they kill the parasites. Yes, correct. Parasites. So I told you guys, when you get a parasitic infection, your eosinophil count goes up. So because the main role that has to be played by the eosinophils are killing of the parasites. And also they play a role in allergic reactions. We all know that anaphylaxis or allergic reaction. Eosinophils are important in that. So they are about 1.3%. Basophils release heparin and also histamines because they play a role in the allergic responses. So so the basophils, they release histamine and also they release heparin. Then monocytes, what is their function? Phagocytosis of large particles in the infections like typhoid or malaria. So guys, so monocyte, I told you, this is the structure, guys. Here, this one. So this is the macrophage which has been formed by the monocyte. So monocyte only enlarges up to this size, macrophages. And then what does it do? It will engulf that bacteria or virus and completely break it. That's the innate immunity. So as I have mentioned here, the monocytes, phagocytosis of large particles in typhoid and also malaria. Lymphocytes, they produce antibodies. B lymphocytes, no? B lymphocytes produce antibodies. Okay, so guys, as I told you before, the white cell types, they can be broadly divided into two categories. What are they? Granulocytes, the three granulocytes I told you, neutrophils, basophils, and eosinophils. And also you have the A granulocytes, that's lymphocytes and monocytes. Their individual functions again mentioned here, but I'm not going to go through that because I have already explained that to you. Okay, the neutrophils, phagocytic action. Phagocytic means like this. They go and engulf or they go and encroach the bacteria and put it really under control and destroy it. So phagocytic pathogens and cellular defense. Then eosinophils. So they have granules containing digestive particles. So granules containing various so they say digest large pathogens. Here you see, use granules. There are granules inside the eosinophils, and those granules they will go and destroy and destruct phagocytose various outside organisms. Here you can see that granule contents to use granule contents to uh, digest large pathogens such as worms and reduce inflammation. Okay, so eosinophils, their main role is in the inflammatory pathway, inflammatory response. And also they particularly play a role in parasitic infections and they kill the parasites, eosinophils, and also worms. Then you have basophils. Basophils, they promote blood flow to injured tissues and also the inflammatory response. I think most important you have to remember under basophils are they play a huge role in the inflammatory process. A granulocytes, lymphocytes, I told you B and T lymphocytes, B cells produce antibodies, T cells directly attack the cells, particularly they are called natural killer cells, they particularly attack the cancer cells. Monocytes, I told you monocytes become macrophages. That macrophage will go and engulf the bacteria or phagocytize the bacteria. Right. Okay, time is running quite fast. Guys, take just a 2-minute break just to refresh yourself. Have a glass of water, 2 or 3 minute break, not more than that. So now the time is 10:23. We'll start sharp at 10:25. 2-minute break. Just maybe 3 minutes. Right. Okay. So we are going to talk about functions of white cells next. Until such time, take a 2-minute break. On. Okay. The functions of white cells, guys. There are very important functions of white cells. What is the most important thing is it play a huge role in the phagocytosis. That means immune mechanism, innate immunity. So neutrophils and the monocytes, yeah, neutrophil and also the other one is macrophage or the monocyte. They engulf, they engulf foreign particles and bacteria through their phagocytic action. So that's a very important function of our white cells. What is that? Phagocytic function, phagocytosis. Phagocytosis that go and encroach the bacteria, encroach the organism foreign particle, and put it inside their cell like this. Yeah? Encroaching and encroaching and engulfing, and that is called phagocytosis. Then the body defense. White cells, they produce antibodies by the B lymphocytes, and they are the main armamentarium, main weapons to go and kill the bacteria, fight against the bacteria. Weapons. Our weapons are our antibodies produced by B lymphocytes. So they are also white cells. Then formation of fibroblast. Lymphocytes may be converted to fibroblast in the area of inflammation and help the process of tissue repair and regeneration. Okay. So they also have a role in formation of fibroblast, but that's not that important. What you need to remember the first two things, that is phagocytic function, and the other one is the body defense. That's called the innate immunity. Sorry, antibodies are not innate immunity, that is adaptive immunity. Adaptive immunity. Phagocytosis is innate immunity. You write that down. Phagocytosis is innate immunity. What do you mean by innate? That means you are born with that immunity. You are born with neutrophils. You are born with macrophages. That means innate immunity. Phagocytosis is one component of innate immunity. And the body defense due to hormones. So you can write hormone defense. That's due to adaptive immunity. Okay, platelets. So now we talked about white cells. White cells are done. So we know the main role of white cells to play are like you need to fight against the bacteria or foreign particles, that is by phagocytosis. Then the eosinophils, they play a huge role in killing of parasites. and also various worms. So that's why they have release of their granules causing uh, damage to these foreign particles or foreign organisms. That is the immune function of the eosinophil. Then even basophils, they also have a immune surveillance action. All right. Yeah. So that is what's happening in white cell series. Right. Platelets. Now, guys, platelets, they are very tiny structures, but their role to play is huge. Why? For you to get a blood clot formation or for you to get coagulation, you need what they are called platelets. Look at this. Now here, this blood vessel is broken down. Maybe there's a step injury or something like that. It's broken down here. So the wall mucosa is damaged here. All right. So here you can see this is a broken blood vessel and all the cells are exposed. Then what will it do? So, yeah, yes, yeah, 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 yeah. Hmm. What is the blood pressure now? Start dopamine. Hmm. Okay. Today all the patients are getting bad. Anyway, it's okay. Really terrifying day, right? So you can see here what's happening when a blood vessel is injured. So maybe stab injury, maybe just a wound, like very early or acute wound or something like that. So you can see here when there's an injury, the vessel wall that get breached or broken down. Then what happens? Your coagulation pathway or the clotting cascade get activated, and that forms a fibrin clot. Can you see this fibrin mesh, the purple colored fibrin mesh? Inside that, your platelets go and get embedded, and that's how you form a blood clot, right? So inside this fibrin mesh, platelets they go and get clumped together, or they go and get embedded, and then it heals. It seals off. Yeah, seals off this defect. You can see again same picture. Damaged blood vessel, and then after some time, this nice platelet being produced and the seal by, like I mean, the defect is sealed. Okay, so these are the functions of platelets, guys. So platelet does not just straight away go and get deposited in the defect. Initially, few platelets come there, so that's called platelet adhesion. So platelets get attracted to the site of injury here. So when a blood vessel is damaged, one important factor comes there. That's called 1 Willebrand factor. What is that factor called? VWF, or 1 Willebrand factor. So when a blood vessel is injured or damaged, then 1 Willebrand, yeah, when the blood vessels are damaged and if the bleeding is severe, you have to give, uh, um, yeah, sorry, I'm just missed that part. Now what happened is, guys, when you get a defect here, when you get an injury or something like this, eye stab injury or some wound or something like that, then the platelets first need to come in there. Then in that fiber they have to get embedded. How does that happen? So initially platelets get adhered to that defect. That's called platelet adhesion. So platelet adhesion, or platelets get attached to that site. That's the first process, adhesion. Look at this. Addition. Then, guys, on top of the other, platelets get clumped together on that platelets which got adhered. So the platelets which got additions to the defect wall, then more and more platelets come and get sit on that. That's called platelet aggregation. It's not here. So deposition is there, then comes the aggregation. Yeah, aggregation. And also the other pathway is secretion. So platelets get, so additions are there, platelets get clumped together in that fibrin clot, and then they multiply, or they more and more platelets come and go and get attached to it. That is called platelet aggregation. And then finally it makes nice blood clot, and you don't have any more bleeding. So you understand how how the bleeding settles in a patient uh, with the help of this clotting cascade, and also with the help of platelets. So what happened is, whenever you get an injury, you get this fibrin clot being formed. We are going to teach you that in a short while, how the fibrin clot is formed. So you get a fibrin clot, fibrin strand, and in that fibrin strand, the platelets get embedded. So initially you have what is called addition of platelets to that defected site with the help of 1 millibrand factor. Right. So once the platelets get aggregated, then once the platelets get additions, then they have secretions of various substances, and to that you get more and more platelets coming and sitting together and makes big nice blood clot. You don't have any more further bleeding, and that's called platelet aggregation. So these are the functions of platelets, as you are aware. So platelet function, I told you, addition, that is deposition of platelets on the subendothelial matrix. Deposition of, so when there's a defect like this, here there's a defect. So platelets come and sit here. So when all the platelets gets adhered to that defect, then what happens is they will start secreting, and then they will start aggregating, and they will make a nice seal here, nice packed environment, and you don't get any more bleeding. So that's the function of platelet adhesion. That is deposition of platelets on the subendothelial matrix. Subendothelial, inner side. The inner side is called subendothelial. Then aggregation is platelet to platelet cohesion. So platelet to platelet cohesion is called aggregation. What is secretion? The release of platelet granules. I told you guys. So platelets, they have granules inside it, and when they release these granules, then they attract more and more platelets there. And remember, it also has a procoagulant activity, platelets. That's why in patients, those who have got multiple risk factors, cardiovascular disease risk factors like diabetes, hypertension, hyperlipidemia together, maybe patient has got some CKD also, that type of patients have to be on aspirin. So what is aspirin? Aspirin is antiplatelet drug. So the people, those who have risk factors for cardiovascular disease, to prevent strokes, to prevent major myocardial infarction, and even other, uh, uh, in those things, we need to block these platelets. Why? If the platelets clump together, that's not good. Why? Patient will get multiple blood clots, and their ischemia will get worse. So therefore, you have to give antiplatelet drugs. So that is what I meant as procoagulant activity. Right. So guys, so we discussed about the functions of platelets. So functions of platelets, mainly they have addition, secretion, and aggregation. Why? To form a nice blood clot. So can you see, guys, in this picture? Can you see this small picture? Can you see this fibrin mesh? So this is a fibrin mesh taken from electron microscope. This is a fibrin mesh, and in that fibrin mesh you have deposition of platelets. Look at that. All right. So now we have to understand how this fibrin clot came from. So for that we need to discuss what is called coagulation cascade, coagulation pathway. Okay. So when you take coagulation pathways, there's an intrinsic pathway and an extrinsic pathway. What are the two pathways? Extrinsic pathway and the intrinsic pathway. So now extrinsic. First, let me talk about the easy pathway, extrinsic pathway. Extrinsic pathway, guys. the very important factor that play a role before it forms the common pathway is factor 7. So extrinsic pathway, the most important factor is factor 7, right? And in the intrinsic pathway, you have factor 9, factor 8, factor 9, factor 11, and factor 12. Okay, so factor 8, 9, 11, 12. 8, 9, 11, 12. 8, 9, 11, 12. Those are factors in the intrinsic pathway. Guys, these pathways are individually tested. Say, for example, the extrinsic pathway, where you have factor 7, there any defect is detected by like prolongation of their relevant investigation. So what is the relevant investigation in the extrinsic pathway? Doing the prothrombin time and INR, PT, INR. So remember, guys, extrinsic pathway, this pathway, extrinsic pathway, the most important coagulation factor is factor 7. And when there's a factor 7 deficiency, you get prolongation of the extrinsic pathway. That means you have prolongation of prothrombin time, which is also called INR, PT-INR. Okay. So when you have a problem of extrinsic pathway, that is when there's a factor 7 deficiency, then that can be detected by doing the PT-INR. So prothrombin time will be prolonged. Right. Then the other pathway, so that's the intrinsic pathway. Then the other pathway is called the extrinsic pathway. That's the extrinsic pathway, and the other pathway is called intrinsic pathway. So extrinsic pathway, the most important factor is factor 7, tested by prothrombin time and INR. And in the intrinsic pathway, the most important factor is factor 8. Intrinsic pathway. So intrinsic pathway, guys, 9, 10, 11, 8, 9, 11, 12. 8, 9, 11, 12. So they both meet in the common pathway. Can you see this? Intrinsic pathway and the extrinsic pathway, they both connect in the common pathway. Okay, so that's the common pathway. So in the common pathway, guys, you have factor 10. So from the intrinsic pathway, from the extrinsic pathway, you have factor 10. You can see that factor 10 that comes in the common pathway. And then with the help of factor 5 and also ionized calcium, what they do is they activate a factor 10 that converts prothrombin into thrombin. So that is factor 2 is converted to still the factor 2. So prothrombin is converted to thrombin. That's in the intrinsic pathway. So intrinsic pathway, factor 9, 8, 9, 11, 12. And this intrinsic pathway is measured by doing APTT or activated partial thromboplastin time. Activated partial thromboplastin time, APTT. Activated partial thromboplastin time. So intrinsic pathway 8, 9, 11, 12, that is deficiency is measured with the intrinsic pathway assessment, that is APTT. Right. Okay. So guys, as you can see here, when the common pathway factor 10 is activated, that converts prothrombin, right? Prothrombin is factor 2, prothrombin into thrombin. And thrombin per se is not enough. So thrombin has to convert it to the fibrin clot. Okay. So with the help of thrombin, then what it causes is fibrinogen is converted to fibrin clot. Right. So it's like this, guys. So again, follow this. So intrinsic pathway, the important factors are factor 8, factor 9, factor 11, and factor 12. They are measured by APTT. Extrinsic pathway, what is the most important factor? Yeah, you talk along with me, then you will remember. Extrinsic pathway, the most important factor is factor 7. And when that is deficient, your PTINR will be prolonged. Right, guys. So then they both meet in the common pathway with the factor 10. And in the common pathway, what happens with the help of factor 5 and also calcium and lipids, the prothrombin is converted to thrombin. And what is the action of thrombin? That will make your fibrinogen into fibrin clot. Fibrinogen into final fibrin clot, which is factor 30. Okay. So that is about clotting cascade or coagulation pathway. Right, good. Right. So guys, look at this, the scale. Now usually your thrombosis and bleeding, they have a fine balance. Thrombosis means ability to cause blood clots, and on the other hand, you have ability to bleed. Right. So you look at this, activation of coagulation, activation of antifibrinolysis, that will make thrombosis. So activation of coagulation pathway that causes thrombosis, blood clot formation. Right. So that activation will lead to blood clot formation, increased blood clot formation, and you can end up with either arterial strokes or venous strokes. By clots, no. Then the other pathways where you have bleeding pathway, where you have inhibitory function, inhibition, no activation, it's only inhibition. There is yeah. So one is So one is fibrinolysis, and the other one is anticoagulation. There's a fine balance, guys. So you can see here on one side there's clotting, and the other side there's bleeding, and you have to balance this very smoothly. So what are the things which play a role in this hemostasis? The blood vessel itself, the platelets. Congratulations. Coagulation. I'm sorry, I didn't see it. Vessels, blood vessel factors, platelet factors, coagulation factors, and also fibrinolysis. So this is how it maintains the balance. Why? When you get a blood defect in the blood vessel, I'll draw it for you. Look at this. So this is a blood vessel. This is the blood vessel. In this blood vessel, now there's a damage. Here there's a damage. So guys, you need a blood clot. Here, look at this, please, all of you. You need a blood clot only to the size of this defect. Okay, you need a blood clot only to the size of this defect. You don't want a huge blood clot. So that's why, guys, we need to have a balance between thrombosis, which is blood clot formation, and fibrinolysis, or the blood clot dissolving function. So we, in our body, we have fine mechanism, fine balance. The blood clot will be formed only to the shape of and the size of the defect. That's why we have this balance. So excess blood clot formation is inhibited by a factor called antithrombin 3. Antithrombin 3. Right. So the components which play a role in that fine balance is the blood vessel factors like 1 millibrand factor, platelets, coagulation factors, and also fibrinolysis. Right. So when it comes to the blood hematology, the physiology of hematology or physiology of blood, those are the essential things that I wanted to teach you tonight. So I think the most important physiological parts you have understood today, tonight. Now, like if you're not that familiar with the coagulation pathway, I will teach you that again. Guys, everyone, just listen to me, everyone, quickly. We were supposed to finish by 10:45, so just give me some time. So guys, when you get a defect like this, we need to form a blood clot. And this blood clot formation is called coagulation. And that happens due to various clotting factors. They are produced by the liver. They need vitamin K for activation of these clotting factors. There are two pathways where you get blood clotting. One pathway is called extrinsic pathway. The most important factor is factor 7. The other pathway is called intrinsic pathway. The most important factors are factor 8, factor 9, factor 11, and factor 12. Okay. So intrinsic pathway you check or you measure by doing APTT, and the extrinsic pathway you measure by doing the PTINR. They both meet in the common pathway. There you have the factor 10, activated factor 10. Activated factor 10 with the help of calcium lipids and also with the help of factor 5. They convert the you know, antivenom serum, ABS. Yeah, 10 units of ABS dissolved in normal saline. 100 mil, give it over 1 hour. ABS 10 miles. But so when you are giving ABS, put 2 IV cannula, and because there might be any reaction. No, you never give hydrocortisone, but keep adrenaline ready. You might have to use adrenaline, right? Okay. So just give, or you just repeat the WBCT in 6 hours time. 6 hours, huh? Not 2 hours, 6 hours time. Okay. If it is again prolonged, again you have to repeat the ABS. Right. Snake bite. Right. Anyway. So I was talking about the two pathways. So with the help of common pathway, that is factor 10, and with the help of factor 5, calcium and lipids, then what does it do? It will produce prothrombin to thrombin. Prothrombin is factor 2, and that will be converted to activated thrombin. What is the function of thrombin? Thrombin will form fibrinogen into fibrin clot. This one here is final fibrin clot. So inside that, platelets go and get adhered, and they start secreting, and then they get aggregated, and they will nicely seal off this defect. Right. So that's the end of hematology, physiology of hematology. Right, very briefly, basic immunology. Basic immunology. So what is immunity, guys? Immunity is the ability to fight the foreign material. Ability to fight the foreign material, that is called immunity. So we need immunity to get ourselves protected from, right? So we need some immunity or some resistance for the outside bacteria, viruses, fungi, parasites, cancer cells. When they come into our body, we need to have some mechanism to protect ourselves. And that's why you have this immune system or immune path. When you take immune system, guys, there are first line immune or first line defense, and also there are second line defense. So let's look at that. So basic immunology, the immune system, our ultimate line of defense. So look at this. Now, when you take the immune system, guys, there's an external component and an internal component. External component is we all have a skin. This skin is huge immune barrier, isn't it? Why? Otherwise, we will have, if we did not have our skin, what will happen? Yeah. You know, all the bacteria, viruses, fungi, parasites, worms, snakes, dogs, cats, everything will enter our body and will eat us into pieces. So skin is the one of the most important immune systems, skin. Then also you have mucous membrane. So inside our nose, mouth, everywhere we have a mucous membrane. This mucous membrane, they secrete various substances which can kill bacteria, which can kill viruses, which can kill fungus. Right? So skin and mucous membranes. Then, yeah, so that is external immunity. Then we have internal immunity. So when we talk about internal immunity, now we are coming into a bit of a tricky area. So when you take internal or endogenous immunity, right, that can be divided as first line defense and second line defense. So internal or within ourselves, like when we want to develop immunity, that can be either first line defense or the second line defense. What are they? So first line defense is the innate immunity, where the blood of the yeah, where you have neutrophils, they will go and engulf the bacteria or virus and will phagocytose them. So the most important function I told you earlier, what is it? Phagocytosis. Phagocytosis. So this is first line defense. First line defense. And it happens immediately after injury. So very acute. So the first line defense in internal immune mechanisms are phagocytosis. Phagocytosis. So what do you mean by phagocytosis? So if this is the molecule, if this is the neutrophil or the macrophage, and this is the artificial bacteria, outside bacteria, it comes to the cell, and then cell will go and engulf that. Right. So that's called phagocytosis. Identify and exterminate. Then also for this innate immunity, not only the phagocytosis, they also can have NKC, that is natural killer cells. Natural killer cells. So attacks the mutated or cancer cells particularly. Okay. So first line defense, you have the phagocytosis mainly by the neutrophils and also by macrophages. Then you have the first line defense, natural killer cells. So natural killer cells, they will attack the cells, but yeah, so they can attack the cells, and also they can attack the cancer cells, that is natural killer cells. Then guys, so that is about first line defense. Then you have what is called second line defense. Second line defense, what is that? Guys, second line defense means, so we call it first line. Why? Just speak a bit. So why do we call it first line? When a bacteria enters your body, these cells go right to the forefront, like neutrophils, macrophages, they go right to the forefront and engulf them and kill the bacteria. So that is innate immunity. Then guys, the next one is the adaptive immunity that comes a little later, maybe few days. That is their lymphocytes, particularly the B lymphocytes and T lymphocytes. The B lymphocytes, they produce antibodies. The B lymphocytes, they produce antibodies against these foreign antigens. Understood? Good. So the second line defense, the cells receive messages from phagocytes, and also they eliminate the enemies. Right. So there's second line defense, the T cells. So T cells, their function is they receive the messages, the T cells, and so from phagocytes eliminate enemies and inform B cells. So they have a helper role to play for the B cells, coordinating role, right, in the second line defense. And this is the other most important one. So even more than T cells, this is the one which is most important. What is that? B cells. B cells. So in the B cells, I told you already, B cells produce antibodies. Right? So B cells are the ones which produce antibodies. Right. Few words on innate and adaptive immunity. Now, what is innate immunity? When we are born to this world, we have innate immunity. That is, we don't get all infections, isn't it? Right. So innate immunity is the immunity which has been there or which is present even at the time of birth. So innate immunity, here you can see here, innate immunity is mainly the cellular immunity. Can you see these guys? So these are microbes entering the cells And you can see in the innate immunity, the epithelial barriers are there, skin barrier and the mucosal membrane barrier. So skin is a barrier, our mucosal membranes, they are also barriers. So there would be disease transmission. All right. So in the innate immunity, as I told you before, it's mainly the cells which play a role. And the most important function of innate immunity is phagocytosis. Phagocytosis. Then there's adaptive immunity. I told you there are two main cell types. So innate means at the time of foreign body entering your body, you have some immunity already. Before the foreign body enters your body, before the virus, before the bacteria entered your body, you had before it enters our body, we had our natural killer cells, then macrophages, all those cells targeted for to kill the foreign material. That is called innate immunity. Now, guys, the other one is adaptive immunity. Which cells are involved in adaptive immunity? The lymphocytes, the T lymphocytes and B lymphocytes. Okay, T and B lymphocytes. So B lymphocytes, they have a huge role to play when it comes to antibody production. Antibody production, because B cells only the ones which produce antibodies to attack the foreign material, foreign bacteria or viruses, whatever. Right. So you can see here, this is a nice picture. That's why I chose this from Google images. So lymphocytes, the B lymphocytes, they release the antibodies to attack the bacteria or offending organisms, and they go and kill with these antibodies. That's in the adaptive immunity. And these are the T lymphocytes, which also play a role in the immune process. Okay, so more pictures showing and explaining innate immunity versus adaptive immunity. So just look at these guys quickly. So characteristics of innate and adaptive immunity. Characteristic of innate and adaptive immunity. So innate immunity, I told you guys, is antigen independent. That is, now adaptive immunity you get only after being exposed to a bacteria, only after being exposed to a virus, right? Or only after being exposed to a fungus. But this one is different. When by the time the bacteria enters your body, we already have armamentarium against those bacteria or foreign substance. So that is called innate immunity. So what does it mean? Antigen independent. Whereas adaptive immunity, antigen is dependent. Right? The adaptive immunity, they don't have antibodies. So what they do is they get adjusted or they get used to that foreign material, and then it becomes antigen dependent process. So innate immunity, very important to remember, the antigen is antigen independent, whereas the adaptive immunity is antigen dependent. That is, once you get the bacteria, once you get the virus into your body, the antigen, and then only we develop antibodies against that. Right. The next difference is pattern recognition. That happens in pattern innate immunity. Then no time lag from the time of exposure. There's no time lag in innate immunity. So innate immunity occurs within few hours, whereas what is this? Adaptive immunity, it takes few days. So very important to remember that. Okay. So the innate immunity occurs very soon after infection. But adaptive immunity, it occurs several days after exposure. Right. So this also, so I think this is beautifully explaining all what you want to know about the cells, white cell types, and their defense mechanisms. So immune system again, guys, another picture, nice one. It can be so immune system. It can be either innate or adaptive. Innate immunity, and also we have adaptive immunity. So innate immunity, guys, it can be physical or phagocyte deviated. What are the physical ones? I already told you, skin, mucous membranes, those are physical ones. So look at that. So innate immunity, two types, either innate immunity or it has phagocytosis. So physical one then, so skin is there, then mucosal membranes are there, right? Cough reflex, all that matters. Then you have the phagocytosis. So there, phagocytosis was the only one under innate immunity. So we have two mechanisms. One is the natural immunity or the physical immunity, and the other one is your phagocytosis. Phagocytosis, predominant innate immunity. So what are the cell types involved in phagocytosis? I already told you. The mast cells, they will form into macrophages. Then you have neutrophils. So neutrophils are there, macrophages are there, natural killer cells are there, and also dendritic cells. So that's important to remember that they ask in the MCQ paper. So what are the cells in the innate immunity? So neutrophils, macrophages, then you have natural killer cells, monocytes, and also dendritic cells, natural killer cells, and also dendritic cells, right? So neutrophils are there. Then you have your macrophages, dendritic cells, natural killer cells. Then, guys, adaptive pathway. So adaptive pathway, I told you, mainly due to lymphocytes. So that there are two pathways. One is the T lymphocyte pathway, other one is the B lymphocyte pathway. So T lymphocyte pathway, you have mainly the helper T cells, CD4 cells. You write within brackets CD4 cells. T helper lymphocytes are CD4. Okay. So adaptive pathway, T lymphocytes, you have the helper T cells, suppressor T cells, and also cytotoxic T cells. So cytotoxic T cells are the ones which have CD8. Then the B lymphocytes. So B lymphocytes are the ones which produce the antibodies. So let me check this. So clonal B cells can be there, and also memory B cells can be there. Okay, adaptive pathway. Okay, right. So this picture again shows you a beautiful explanation, guys. Can you see this? Innate immunity and adaptive immunity. So innate immunity, you can see here the skin barrier, the skin or mucosal membrane barrier. And then these are the cells I told you. What are they? Neutrophils are there. Then macrophages are there. The dendritic cell is there. And also you have the natural killer cell, NK cell. Natural killer cell, dendritic cell, neutrophils are there, and messenger. Then in the adaptive immune pathway, you have the two lymphocytes, that is B lymphocytes, which produce antibodies, you can see here, and the T lymphocytes. Okay. So now we have understood the differences between innate immunity and also adaptive immunity. So innate immunity, the physical uh, ones I told you, innate immunity, skin, mucous membranes, cough reflex, all that. Then the phagocytic ones, there are few cells involved in phagocytosis. I told you already. What are they? Neutrophils are there, macrophages are there. Then your this dendritic cell is there, and the natural killer cells are there. These can come up in your MCQ paper. That's why I'm telling these things. Okay, the adaptive pathway T lymphocytes, they mainly produce CD8 cells or the CD8 cells, and also they so there's cytotoxic T cells. They have helper T cells, which is the CD4 cells. The B lymphocytes, they produce antibodies. Right. Few more words about innate immunity. You can see here. It's a nice, beautiful picture. No, it explains everything. So you can see here macrophage is waiting, and here is the foreign substance. So foreign material, maybe a bacteria, maybe a virus. So the neutrophil that get attracted to this site. So there's attraction. Neutrophil gets attracted, attraction. Then guys, once they get attracted, they get bound to the protein of that foreign particle, protein of the foreign particle, like bacteria or virus or what foreign particle. So macrophage, they get bound to or they get attached to those foreign substances. You can see that here. So non-specific forces, this one completed, and here they have developed antibodies. So this is the neutrophil, they get attached to because it was attracted to these substances, so the foreign substances, so therefore they get attached. So initial word is they get attracted and then they get attached. Anything is like that, no, in life. First you get attracted and then you get attached and then you detach, right? Okay. All right. So that is binding. Then after that, guys, then only the match is over for the foreign object. Why? That will engulf the bacteria and will destroy it. Engulf the bacteria and destroy it. That is endocytosis. So that is what's happening in innate immunity. What are the cells? Neutrophils and macrophages, dendritic cells, and the natural killer cells. Phagocytosis. So innate immunity, few more theory points. Protection against infection that relies on mechanisms that exist before infection. Right? So protection against infection that relies on mechanisms that exist before infection. So that's what I told you earlier. Before the foreign organism, like bacteria or virus entered your body, you already had this immunity in your body. From the day you were born to this world, you had this immunity. That's what I'm telling you. So the infection that relies on mechanisms that exist before infection are capable of a rapid response to microbes and react in essentially the same way to repeated infections. So, right. So, it exists at birth. I told you it starts from childhood days, exists at birth. And be the first line of defense against infection. It's very true. The first line defense against infections are this innate immunity. This is the first line defense against infection. So remember, very important points I stress there. What are they? Innate immunity is present at birth. Innate immunity is present at birth. So even before the infection sets in. So innate immunity is present at birth and before, even before the infection, the mechanisms are activated. Even before the infection, the innate immunity is persisting in your body. So because it's present at birth. Right. So that's about innate immunity, right? So innate immunity is all about phagocytosis, going and engulfing the bacteria and then destroying it. Then guys, you have what is called adaptive immunity. What is adaptive immunity? So adaptive immune system, I have showed you beautiful pictures which I got from Google Images. So you can see this the bacteria or whatever foreign substance. This is germ. So now macrophage that get excited about this. The macrophage get excited to phagocytose the germ. So what does it do? The macrophage shows the germ's antigen to T cells. So it get attached to the the microbe, whatever bacteria or whatever, get attached to the innate immune cell, right? Maybe macrophage, and then macrophage shows uh, the germ antigen to T cells. So this is the antigen, this pink color one, and that is being shown to T cells. So what does the T cells do? So now what happened, guys? So you got the infection. Once you got the infection, what happened? Our first line defense mechanism went in there, and then they just choose one cell, maybe neutrophil, maybe macrophage, and they saw like macrophage shows the germs antigen to T cells. Yes. So the macrophage will engulf the bacteria and that will show up the antigen component to the T cells. So now the T cells or the cytotoxic T cell, the killer cell, is being shown up with this imaging and now it is furious to kill. You can see that no cytotoxic T cell off to kill the agent, to kill him like that. So then also guys, these macrophages, they also stimulate the helper T cells, the CD4 T lymphocytes. So once the bacteria is inside your macrophage, that will stimulate the original organism. So what does it do? Helper T cells shows the antigen to B cells. So now once the germ is encroached by the neutrophil, that will be shown up to the B cells. It will be shown up to the B cells, B lymphocytes. So natural T cells shows these it shows the antigen to B cells so that they will produce more and more antibodies. You can see here, these are the B lymphocytes and they have produced multiple antibodies. So these antibodies go and attack the bacteria or virus or whatever infectious organism. Is that clear, guys, everyone? So adaptive immunity is mainly by the lymphocytes. How do they do that? When the germ or when the microbe is engulfed inside the neutrophil or macrophage, right, they will be shown up. The antigen component will be shown up to the cytotoxic T lymphocytes, and also it will be shown on another day to okay. So here you can see. So this here shown the macrophage is showing the antibody. Sorry, not the antibody, the antigen of the germ to cytotoxic T cell, and also it's showing the antigen of the germ to the helper T lymphocytes. Helper T lymphocytes, what is their function? They activate the B lymphocytes. And the B lymphocytes, what do? They produce antibodies. The B lymphocytes, they produce antibodies. And that will kill the bacteria. Understood, guys? Everyone? Is that clear? I'll try to show you another picture of that. Plug in this device. I think quickly we need to stop. Time to stop. So adapt. So guys, I'll show you with this one. Look at this. So both innate. No, this one. Yeah. Or even this one would be better. What we already discussed. Yeah, this one. Look at this. Innate and adaptive immunity. So guys, in our immune system, in our body, there are two immune mechanisms. One is innate immunity. Right? One is innate immunity. What do you mean by innate immunity? That means at the time we were born, we have this immune mechanism that's called innate immunity, even before the infectious agent entered our body. So it's not deciding on the type of immune response after being exposed to the bacteria or the virus. Because they already have their immune system geared to kill the bacteria. So even before we are being exposed to the bacteria, we have these immune powers. It's present at birth. Okay, right. So what are the types? You have the physical one, physical innate immunity, and also you have the phagocytic innate immunity. So physical innate immunity is skin and mucosal membranes, and the phagocytic innate immunity is your neutrophils, macrophages, natural killer cell, and dendritic cells, which will go and engulf the bacteria or whatever the foreign material and destroy it. That's called phagocytosis. Then you have on the other side the adaptive immunity. So adaptive immunity, what happened um, is mainly showing the activation of T and B lymphocytes. So you can see here is the innate immunity, epithelial barrier is there, the phagocytosis is there, and adaptive immunity, only the two cell types. What is that? B lymphocytes and T lymphocytes. B lymphocytes and T lymphocytes. B lymphocytes produce antibodies, and the T lymphocytes, cytotoxic T lymphocytes, will destroy the organism. Right. Now, adaptive immunity. So, adaptive immunity, which is mainly mediated with B lymphocytes and T lymphocytes, again broadly divided into two categories. What are they? Humoral and cell-mediated immunity. So, adaptive immunity, there are two subtypes. What are the humoral immunity and also the cell-mediated immunity? Humoral and cell-mediated. So, what do you mean by humoral immunity? Yeah. So humoral immunity is once you are exposed to a bacteria, you produce antibodies against them. You produce antibodies against them. That's called humoral immunity. What do you mean by cell-mediated immunity? So cell-mediated immunity is when a foreign cell or infectious cell is presented to you, then what happens? Our natural killer cells and I'm mentioning here, let me read that. So dendritic cells and this side macrophages. So macrophages, dendritic cells, they all um, all those cells. There is what is so the B12 and also the other cell types like they all combine together to activate the T cells. So you can see that no here. Here you can see the macrophage, and here you can see the dendritic. What is it? Yes, dendritic cell. They get activated, and finally they activate the T cell. Okay, so the T cells when they activated, so they can produce killing of the bacteria or virus. When they like when the T cells are attached to it, and then they can cause destruction, as you can see here in this diagram. So that is what is happening in adaptive immunity. So adaptive immunity, there are two types. One is humoral immunity. So humoral immunity is very easy. That's due to production of antibodies by the B lymphocytes. And the little complicated, tricky one is cell-mediated immunity. So why do we call it cell-mediated immunity? Because there are multiple cells involved. So you can see obviously the phagocytes or phagocytosis by the macrophages are there, dendritic cells are there. Yeah. Okay. So that's the second line defense, huh? Humoral and cell-mediated immunity, second line defense. Yeah. Okay. So humoral immunity versus cell-mediated immunity. So see the differences. Now humoral immunity, guys. So they mentioned here the extracellular, that means outside the cell microbes, or cell-mediated immunity, phagocytosis, phagocytose microbes in macrophages. So in cell-mediated immunity, you attack already the bacteria or virus taken up by the macrophage. But whereas the humoral immunity, you just produce antibodies against something outside. That's why you call it extracellular. Right. So here in the cell-mediated immunity, phagocytose um, microbes in macrophages. Okay. So here we can see under humoral immunity B lymphocytes, and you can put arrow and write antibodies. Cell-mediated immunity, you have the T helper lymphocytes and the cytotoxic T lymphocytes. Helper T lymphocytes are CD4 cells, and the cytotoxic T cells are called CD8 cells. Right. Okay. So the functions have been mentioned here. Block. So like this is the type humoral immunity. Yeah. So when you have only humoral immunity, block infections and eliminate extracellular microbes. In the cell-mediated immunity, activate the macrophages to kill. So they attack the bacteria or virus. Okay. So immunological disorder, the final slide, immunological disorder. So there are 4 types of immunological disorders, guys. These also we call as hypersensitivity reactions. So there's type 1, type 2, type 3, and type 4 allergic reactions or immunological reactions or hypersensitivity reactions. What are they? Type 1 is very immediate. When do you get that? It happens very quickly. Type 1 hypersensitivity. They can be asymptomatic also. Type 2, you have uh, type 2 immunological responses, you have cytotoxic drugs and toxic agents playing a role. And in class 3, it's complex mediated. And class 4 is delayed type hypersensitivity, right? So that you don't have to know. All what you need to know is there are 4 types and the examples, right? So example, this is very important. Hay fever. So type 1 hypersensitivity, you have production of IgE. Here it's mentioned here. In type 1 hypersensitivity, you have production of IgE, right? So they have hay fever, allergic rhinitis, eczema, atopic asthma, all that together. Then type 2 hypersensitivity, that is cytotoxic mediated. So examples of class 2, transfusion reactions, hemolytic disease of newborn, things like that. So that is type 2 hypersensitivity reaction. What is that? Hemolytic disease of newborn and also transfusion related infections. So transfusion related reactions, I'm sorry. Transfusion related reactions. Class 3, I told you complex mediated. That means intrinsic allergic alveolitis, and also patient might need serum sickness. Okay, so intrinsic allergic alveolitis. Now it has to be yeah. So intrinsic allergic alveolitis and also serum sickness like syndrome. So serum sickness is also type 3 hypersensitivity, very important to remember that. So intrinsic allergic atopic allergies or intrinsic allergic alveolitis, and also serum sickness like episodes or serum sickness. That happens in type 3. And the type 4, you have delay. Yes, very important. Type 4 is delayed type hypersensitivity reaction. This class 4. So class 4 hypersensitivity reaction examples are the Mantoux test, the Mantoux reaction, and also contact hypersensitivity. Okay, those are the 4 types of hypersensitivity reaction. Again, another easy explanation of the same thing. Type 1 is IgE mediated. Yes, it's atopic, allergy related. So IgE mediated. So IgE mediated, quick onset after exposure is quick. So immediately after exposure, they get symptoms. Allergic reaction develops immediately after exposure. So that's why they say quick onset after exposure. So type 2. So examples of the allergic agents: bee stings, latex, carbon monoxide poisoning. Type 2, cytotoxic drugs. Hemolytic reaction, hemolytic disease of newborn, graft versus host reaction, wood pastures, things like that. Okay. So type 3 hypersensitivity reaction is where you get serum sickness like episode. Okay, here it's mentioned serum sickness like episode, and also various chronic rheumatological diseases like SLE. Look at this, SLE. So serum sickness I told you, and then polyarteritis nodosa, and also hypersensitivity pneumonitis. So those are the type 3 hypersensitivity reactions. What are they? Hypersensitivity pneumonitis, then you have SLE and polyarteritis nodosa. Right. The next type, delayed or cell-mediated immunity. Delayed or cell-mediated immunity. Either delayed or cell-mediated immunity. So that happens in chronic graft versus host reaction, latex allergies, things like that. So disorder or cell-mediated problems. That is type 4 hypersensitivity reaction, delayed hypersensitivity reaction. Very important. Type 4 hypersensitivity is delayed hypersensitivity reaction. So just to revise again, type 1 hypersensitivity reaction occurs immediately after exposure to the allergen. Immediately after exposure to the allergen, or at least within few hours. And they are IgE mediated. IgE mediated. So atopic asthma falls there. Atopic asthma, urticaria. Right. Type 2 hypersensitivity reaction. Okay. So there is hemolytic, that is blood transfusion reactions, transplant rejections. Those are the ones. Then type 3 hypersensitivity reaction means the patient has developed antibodies over a long period. So hypersensitivity pneumonitis, SLE, polyarteritis nodosa, those are the ones. So that is type 3 hypersensitivity reaction. Type 4 is called delayed hypersensitivity reaction. Delayed hypersensitivity reaction. So, chronic graft injections, PPD test, latex, NICT, and also precision. So these are the delayed hypersensitivity reactions. So chronic graft versus host reactions. So chronic graft rejection, Mantoux test, pluripotent derivative test or Mantoux test, latex allergies, those are the ones. Okay, right. So guys, what I did tonight was I gave you full account of hematology, physiology, the physiology part of hematology, which will be benefited for particularly the junior students. Even for seniors, it's important, but for junior students, that would have been really greatly helpful. The physiology of the hematology system, and also protein cascade we finished. Then, guys, we went on to discuss the difficult part, that is basic immunology, but that also we made it simple. Why basic immunology? I taught you that there are two pathways. One is called the innate immunity, the other one is called adaptive immunity. But by the time we are born to this world, we have some amount of innate immunity. So our skin, mucous membranes, they produce, immediate barrier against infection. Then if it enters our body, then you have to individually assess the risk. Okay. So yeah. So the immunology, the innate immunity, adaptive immunity, I taught you. Adaptive immunity, I taught you about the B lymphocytes, how they produce antibodies, and the T lymphocytes, CD4 helper lymphocytes. They help in giving the germ or making it attracted to the neutrophils and also to the killer T lymphocytes. That's the action of CD4 T helper lymphocytes. Cytotoxic T cells, they will not. Right. Okay. So uh, yeah. So then we were discussing about adaptive immunity. So T lymphocytes, T helper lymphocytes, and also cytotoxic T lymphocytes. So cytotoxic T lymphocytes, they kill the foreign material or the bacteria or the virus. And T helper lymphocytes, they shown up the antigen of that bacteria or virus to the cytotoxic T cells for them to kill. And the B lymphocytes, they will produce antibodies against them, right? So that is called adaptive immunity. So adaptive immunity, again, two types: humoral immunity and also cell-mediated immunity. Humoral immunity is the B lymphocytes producing antibodies, and the cell-mediated immunity is the T cytotoxic T cells killing the bacteria or virus. They are also for this killing process, that is cell-mediated immunity. You also have the help of natural killer cells and also macrophages. Then we went on to discuss about these hypersensitivity reactions or immunological reactions. There are four types: type 1, type 2, type 3, type 4. Type 1 is where you have immediate allergic reactions like atopic asthma, uh, then allergic rhinitis, urticaria, eczema, things like that. And it's IgE mediated usually. Then type 2 hypersensitivity reaction, yeah, you get transfusion related reactions. Then where you have organ transplant mismatch, hemolytic disease of newborn, that is hypersensitivity type 2. Then type 3, hypersensitivity reaction type 3 is where you have serum sickness like episode, and also various immunological disorders like SLE, polyarthritis nodosa, so on and so forth. And class 4, type 4, is delayed hypersensitivity reaction.